Okay, so now we're going to spend some time talking about some other sleep disorders. So we spent time talking about insomnia, which is really the most common one that people are going to run into. But there are a number of other sleep disorders that may require treatment and addressing so that people get a better quality of life and better sleep. And so the first group that I want to talk about is some of our disorders of hypersomnolence. So the big ones that we'll see are narcolepsy and idiopathic hypersomnia. So narcolepsy is one you've probably heard about. It is characterized by sleep attacks, which is an irresistible need to sleep during throughout the day, despite having appropriate sleep. So individuals will have this irresistible potential urge to sleep. And sometimes it causes risks when it comes to driving. Sometimes it can be very disabling, very impairing. Individuals with narcolepsy may or may not have what we call cataplexy. So cataplexy is the drop attacks, right? So a sudden bilateral loss of muscle tone. And that's usually accompanied by some sort of emotional experience. So someone might get really excited about something and then they experience a drop attack where they lose muscle tone. They basically kind of fall asleep. And individuals with narcolepsy have kind of a blurring in a way of the transition from sleep to wake, where they may have increases in hypnopompic and hypnagogic hallucinations. They may have higher rates of sleep paralysis. They tend to have strange amounts of time that drop them into REM sleep. So with a nap study, like if they nap, they may go into REM sleep even within 10, 15 minutes of napping, which is unusual for someone who has normal sleep architecture. It can be challenging. There's a lot of different ways that we can diagnose this. So we can do the sleep studies that I've talked about before, but also there are some genetic abnormalities associated with narcolepsy as well. So the HLA-DKB1 star 0602 allele is oftentimes abnormal in individuals who have narcolepsy, and this translates over to a deficiency in orexin, which is one of the chemicals that makes us awake. There seems to potentially be some autoimmune components to this that actually may damage the cells that create orexin. So there's a lot of interesting aspects of narcolepsy that can cause it to happen. Now, it's a fairly rare condition, but it may also be underdiagnosed. I know a lot of people, as part of the hypersomnia community, as someone who has idiopathic hypersomnia and a healthcare provider, so I was able to advocate for myself. It still took many months for me to get diagnosed, but for some people, it's a very frustrating process to get appropriately assessed and diagnosed because there may be kind of minimization, right? So, oh, you're a 30-something-year-old mom who's sleepy. Well, join the club, right? Welcome to being a mom, and minimization. So it's important to really address if someone is literally, I fell asleep at a traffic light while I was driving in the middle of the day. Like, that was not good. That's not okay. So, that this, when things are not, not normal. But sometimes it's hard for this diagnosis to happen. Sometimes it's difficult for people to even take hypersomnia seriously, unfortunately. When it comes to narcolepsy, so there are ways to help treat it. So scheduling of naps actually can be helpful. So individuals with narcolepsy tend to actually feel some refreshment from about a 30-minute nap. People with idiopathic hypersomnia are much less likely to experience refreshment from sleep. So there is a difference there. So idiopathic hypersomnia tends to not fall into REM sleep and also does not have that refreshment from naps. But napping scheduled can be really, really helpful for people with narcolepsy. Now, when it comes to medications that can be helpful for narcolepsy, we have wakefulness promoting agents. So most commonly what you're going to see are stimulants that promote the release of dopamine and norepinephrine. So those are going to be things like Nuvigil, Provigil, Adderall, Ritalin. But we also have newer products like pitolisant that also are not stimulating in the same way, but can promote wakefulness. So the differences, like I mentioned before, between type 1 and 2 of narcolepsy, type 1 has cataplexy, type 2 does not. Now, there are different medications that can be used to help manage the cataplexy symptoms that we'll talk about in a moment here. So for narcolepsy and hypersomnia, if someone has cataplexy, they can benefit from certain types of antidepressants, which modulate serotonin and or norepinephrine, and norepinephrine with venlafaxine. So venlafaxine is probably the most common one that we'll see, but fluoxetine can be helpful. Clomipramine can be helpful, which is a tricyclic antidepressant. And then sodium oxybate, which is a drug that's actually only procured from a specific pharmacy through a very specific program. So sodium oxybate used to be a product that was used to drug people for assault. I won't go into detail because we are on YouTube, but drug people for assault. But the thing with sodium oxybate is it seems to improve the quality of sleep during nighttime for people who have idiopathic hypersomnia and narcolepsy with cataplexy to help improve their wakefulness during the day. And typically someone will take it at bedtime and then take it a number of hours later. One of the challenges with it is because it's hard to procure, but also because it contains, particularly the Xyrem, actually contains a large amount of sodium salt, which can sometimes be difficult for people to take. But it's at a scheduled timing so that people will have better quality sleep, essentially, so that they can function better during the day. So I had mentioned previously too, there's pitolisant or Wakix, as well as solriamfetol or Sunosi, and these work to help promote wakefulness different than our stimulants do. So these solriamfetol inhibits the reuptake of dopamine and norepinephrine, while pitolisant is a histamine antagonist / inverse agonist. And if you remember from pharmacology, an inverse agonist elicits an opposing effect, an opposition effect. So essentially, we're seeing kind of this mixed effect on histamine with pitolisant. Now, other options that we mentioned are stimulants, right? So we have Provigil, we have armodafinil, we have products like methylphenidates. Good luck getting them right now in 2023. Vyvanse, Adderall, etc. So the stimulants can. Now, products like Provigil and Nuvigil or armodafinil and modafinil work more specifically on just sleepiness. So they don't have as much of a use in ADHD, but they, as a whole, all of these stimulants will help make people feel more awake. Other things we look at are our circadian rhythm disorders. So we mentioned non-24-hour sleep, which is for individuals with blindness. But we also see times where people will fall out of synchronization from jet lag as well as shift work. So typically with jet lag, we will use light adjustments, if you will, and melatonin products. So melatonin over the counter, a good supplement, or Ramelteon Rozarem. For shift work, lights, blackout curtains, strong artificial lights, trying to simulate the day-night cycle as much as possible is going to be one of your best things to do. Now, a lot of times people may need another product like a wakefulness promoting agent, such as modafinil, which is approved for shift wake disorder. I did want to take a moment to mention obstructive sleep apnea. Really, the best thing for obstructive sleep apnea is a CPAP machine, which is the machine that forces air into your lungs while you sleep. So there's not really medications that will treat sleep apnea, so I don't really talk about it here. There are some stimulants that we can use sometimes if someone is using their CPAP machine appropriately and it's working appropriately, but they're still having some daytime sleepiness. A moment for parasomnias. So parasomnias are abnormal behaviors or physiological experiences that happen during sleep from someone, and it can be exaggerated. It can be hyperbolic. So we all kind of have nightmares sometimes. People may have, may mutter in their sleep from time to time. But for it to be a parasomnia, it is very much an abnormality. So that can be a parasomnia of arousal, so sleepwalking and sleep terrors that typically happens during non-REM sleep. We can see sleep talking during sleep-wake transition. So I actually do this. I can have a conversation with someone and have no recollection, but it's not a conversation like a muttering one, like an actual cohesive conversation. No idea that I had it. REM parasomnias include things like nightmares, acting out at night. There's really no true treatment for it, unfortunately. It's really mitigation of the fallout of it and management from that perspective. When we're thinking about substance and medication-induced sleep disorders, we want to think about what types of products may cause activation or wakefulness, which products may cause depression or sleepiness, and which ones can have kind of a mixed effect for people just depending on the individual. So activating agents can include stimulants like amphetamines, caffeine, cocaine, steroids. Our depressing agents can include antipsychotics, especially some of our newer ones that have antihistamine effects. Cannabis, particularly things like the CBD component, the cannabidiol component, opioids, which are traditional CNS depressants, and benzodiazepines. So these ones can cause hypersomnia, sleepiness, CNS, central nervous system depression. Alcohol, antidepressants, and beta blockers can kind of have a mixed bag of effects on different people. So alcohol, like I had mentioned before, has a CNS central depressant effect. It can make you sleepy, but it also releases chemicals into our reward pathway, and it can do a lot of other things because it's a very small molecule. It does a bunch of different things. So it can be activating for some people. And depending a bit on the dose as well, it can then be sedating. But the sleep quality actually is suppressed with alcohol. So people may fall asleep, but the actual restorative nature of their sleep is inhibited. Antidepressants can make people awake sometimes. It can make them feel sleepy. It can do neither of them. It also has some effects on our REM sleep, but the implications of that don't seem to be significant based on really at this point decades of data. Beta blockers can cause fatigue and sleepiness and can have some challenges when it comes to the an individual's fatigue and sleepiness, and they're blood pressure medications, but are also sometimes used for anxiety. When we want to think about those conditions, right, mentioned before, but we want to address those conditions. This is our kind of summary of conditions, right? Cardiac, pain, GERD, head injuries, endocrine challenges like thyroid and diabetes, Parkinson's, pregnancy, pulmonary disease. And then, of course, poorly controlled mental health conditions can also contribute to sleep disorders. So to break things down, right, there are the two theories of why we sleep. We have recuperation, we have adaptation, we have our REM stages, 3 to 4, depending on where you look. If you were in my course and I'm testing you, I will make that very clear from you understand if you're looking at different places, you're going to see slightly different descriptions of like the 3 stages of non-REM and then REM, or 4 stages. It gets a little weird depending a little bit on where you look. Sleep deprivation can cause sleepiness, especially during slow wave sleep, but not as much during REM. Circadian rhythm are cycles of functioning, and there's a number of brain parts that are associated with it, which we talked about with our nuclei earlier, and are in response to our day-night cycle, but can still maintain even if we don't have exposure to a traditional day-night cycle. These are our 4 areas that are involved in sleep. So our posterior and anterior hypothalamus, as well as our reticular formation. So our reticular formation, as well as our caudal reticular formation, which is our sleep nuclei. Sleep disorders, we have insomnia, which is an inability to sleep due to difficulty in sleep or poor quality for 3 nights for 3 or more months. We like to do non-pharmacological stuff, but we can use some of those sedating agents such as short-acting benzos, non-benzodiazepine receptor agonists such as Z-drugs, orexin, etc. Narcolepsy, we use stimulants, stimulants, pitolisant, not suvorexant. Don't use suvorexant there. I apologize. Antidepressants, we can use our sodium oxybate, solriamfetol. So I put pitolisant and solriamfetol together. I apologize. We've got our non-24 hour, shift wake, jet lag. those can be affected by melatonin. Parasomnias are a bit of a mystery for treatment from my perspective. And then these are medication options, right? So we've got our short-acting benzos, our non-benzos, melatonin receptor antagonists, orexin antagonists, sedating antidepressants, antihistamines, which we typically don't recommend because of their anticholinergic properties, the tolerance that develops over time. Over-the-counter supplements, I really just recommend melatonin there if it's a good product, not too high of a dose. Take it consistently. Don't take it right before bed. Take it a little earlier than that. Our stimulants for hypersomnolence, modafinil, armodafinil, our amphetamines, and our methylphenidates, and then some of our miscellaneous stuff for narcolepsy. I hope you enjoyed our series. It's over. I hope you learned something. I know I did. I learned how to use my computer better, which I always try to do. But I hope you enjoyed it. I hope you learned something. Take care, and thank you for listening. I think some of you probably had to, so